Good morning, everyone. We'll start on time. So this is a teleophthalmology session by TOSI in AIOCMT3 Dehradun. So myself, Dr. Prasanna Venkatesh, will be moderating it. We have our chairperson, Dr. BNR Subudhi sir, along with the co-chair and conveners who will be joining us shortly. Without much delay, we'll have the first topic, sir.
Yeah, my trust.
Yeah, by our dynamic BNR Subudhi sir. The journey of TOSI will be covered by sir, followed by the 7 talks that we have lined up. Over to you, sir, for journey of Teleophthalmic Society of India.
Very warm good morning to all of you, my dear friends. As you know, the teleophthalmology is one of the new branch of ophthalmology coming into the horizon. Maybe this is still in the infancy stage, and in due course of time it will pick up, and next decade we will see that teleophthalmology or telemedicine in any faculty of medicine will be one of the most important branch, because as you know, our clinics are overcrowded nowadays. We get lot of patients. So can we reduce our OPD by cutting up some OPD by doing some sort of teleophthalmology? So let us say follow-up, let us say anything. You want to give the some say consent, everything, or any guidance to the patients can be done through teleophthalmology. So you have a only simple thing, you have the software and teleophthalmology. Set in your hospital where you can connect to the patient, innumerable patients where it will be practicable. So I think next decade we'll see that that's why we are promoting this branch in various forums, and as I said, lot of us are doing teleophthalmology in our individual practice, but there is no coordination between this teleophthalmology practice amongst us. And we must join together so that it will be a common platform where we can share our work and we can share our knowledge amongst us, so that we can improve further, and we will see that ultimately the patient gets the benefit from this. So how we started this program? So that is the journey. So as you know, in the corona period, we all were indoors. So there were no patients. We were sitting within the 4 walls. And suddenly somebody, something mind came to how we connect the patients, because a lot of patients were coming to the clinic but unable to show us. We can't see them also because of the fear of COVID. So we planned to start this teleophthalmology society. At that time, telemedicine was in the horizon, and telemedicine was doing a lot of work at that time. So we said that why not start teleophthalmology, and we started the teleophthalmology. So launching of teleophthalmology was held on 4th April 2021 in presence of President and Secretary of AIOS. I will tell you the inauguration ceremony, how we conducted the inauguration ceremony. President of Telemedicine Society of India, and few international dignitaries working in the field of teleophthalmology, all the members of executive committee virtually. At that time it is not possible to meet physically, so we started and we launched this society virtually, and we registered the society after 1 year. That's the 4th February 2022, we registered the society, and this is the teleophthalmology office. I am the Secretary of the Teleophthalmology Society of India, and this office definitely has stationed in my clinic, my hospital. So this is the TOSI office, and these are the constitution and bylaws we have started. And this is our mail ID, tosi.india gmail.com, and the website is tosi.org.in. Sometimes we get a lot of updates in there, but still we have to continue our updation in this website. So all the members can access this and can give us ideas how we can improve this website, and we can place it in the future. So this is the bank account, and this is a TOSI application form. It's a very simple form, just few data we require, and office is in our hospital. And please encourage your friends, because everybody is doing teleophthalmology in some sort of, because nowadays we do a lot of vision centers and a lot of clinics outside your base hospital. So you connect with them. How you connect them? By teleophthalmology only. So be a member of it. We will provide you some sort of, our friend Dr. Senthil will tell you how you can start your business practice in your clinic itself. So these are the R&R, the membership details. So far we got 46 live members and 4 associate members. We completed half century, that's 50 members. We have live members. And so much activities done, as I told you. We launched this TOSI on 4th April 2021, by the President Secretary of AIOS, President Telemedicine Society of India, and interested dignitaries. So it was a grand success. And of course, we did another virtual symposium and official inauguration on the 5th May 2021 in the presence of none other than Bollywood star, Mr. Boman Irani. He was the chief guest, and other speakers from different fields of telemedicine, teleopthy, like Dr. S.B. Gogia, Dr. K. Ganapati of Apollo Telemedicine Network, Dr. Sunil Shroff from Telemedicine Society of India was the president at that time, Dr. Ganesh Joshi from CRC Bhopal, Dr. Padmaja Rani at that time, she was not a member, she was our guest at that time from Elvita Institute, and so many other medicine network people, they have joined with us in the first virtual symposium on 5th May 2021. Then we collaborated with a non-profitable organization called Eco India, and because their main aim is to supply a platform for the education and for the programs, safety programs, etc. So we collaborated with them with the TOSI Eco, and we conducted so many education programs in the country. Like we have organized 6-month-long TOSI Eco Education Program 1. That's a diabetic retinopathy for ophthalmologists, because everybody, all the ophthalmologists, no doubt they are updated, but still lot of things are coming up every day, lot of research is coming up. So to update all our friends all over the country, we conducted this program, the 6 months long session, education program, diabetic retinopathy. Every fortnight, one of our member of Teleophthalmology Society of India gave a talk on various aspects of diabetic retinopathy to all the ophthalmologists all over the country. We connected more than 1,000 people all over the country. This is the session details. Every fortnight we have our Dr. Rajiv Raman and Dr. Kim, Dr. Natarajan, Dr. Senthil, Dr. Sheila John. All these people were given lot of updates on the diabetic retinopathy. So then second program was conducted on 12th June 2022. It was on optometry for all the optometry, because we ophthalmologists mostly for the diabetes screening or glaucoma screening, we depend upon the optometrist. So unless we take the help of optometrist, we cannot continue our work on teleophthalmology. So we did education program for them too. That again every fortnight one of a Teleophthalmology Society member, and teleoptometry also, we got teleoptometry 4 members, associate members, they gave talks to all the optometrists in the country and abroad also. Many people, more than 350 people that joined on that day program too, the 12th January 2022. This is the schedule we have conducted for the optometrist. So then we had a pan-India diabetic awareness program 2021-22. We asked most of our stalwarts in ophthalmology like Dr. Lalit Verma, Dr. Rajiv Raman, so many, all the senior people, they gave 1-minute video talk. So this is an awareness of the diabetic retinopathy in the society. We started particularly on the January 23rd, being the occasion of birth anniversary of Netaji Subhash Chandra Bose, and he belonged to the state of Odisha. So we to create awareness of diabetic retinopathy leading to blindness and importance of annual eye checkup. We stressed, so teleophthalmology stressed all the diabetic patients to check their eyes annually. So every week, initially started twice a day, then once a day. We continued about 6 months to 1 year. I'll undertake 2-3 minutes I will take. And so this is they are the speaker. Then we had education program 3 for optometrists, DR screening and grading. So unless you did optometry, they know about how to grade the diabetes patients, diabetic retinopathy patients, how they will refer. So we gave a simple basic education to them through the virtual, through this teleophthalmology platform with the TOSI Eco platform, and how to grade the diabetic retinopathy so that they can refer the patient, they can counsel the patient whether they need any treatment or any reference. So that continued for another 3 to 4 months. This Then of course, then we continued our program with the nurses, because many times the nurse is the first point of contact with the diabetic patient. So they should also be aware of diabetic retinopathy, and they should also know how to, which is the serious patient, which is required the diabetic retinopathy treatment, which are the patient require immediate help. So we have educated the nurses all throughout the country on this in the February 2020, that means this year. So these are the class schedules. We got 4 sessions, and each one of our members, they started this session. Then we published a newsletter online. This is about every quarterly. We conducted about 2 to 3 newsletters till date, and we are waiting for our journal to come now. Journal, we tied up with JP journals, the JP brothers, to have a first TOSI journal. That is, this is our first journal about to be published. I request all of you to contribute to articles for this journal, and this maybe this year, end of this year or beginning of the next year, 2024-25 will be coming. I request all of our friends. So first article should come from our members of Teleophthalmology Society, and definitely it will become one of the very interesting journal in the future. So what are our future extension activities we plan? Unless we have a strong membership drive, probably we cannot achieve our success. We have to, everybody, all of us, all the 50 members of this Teleophthalmology Society should work for the improving the membership in your clinics, in your hospitals, in your medical colleges. Please enroll numbers, because we have to have minimum 200 members to affiliate with the AIOs, so that we can have a. But I am very much thankful to Dr. Namrata Sharma. Every time whenever there is a conference in all India level, she invites us as the secretary and president to plus just to have a session. So we have a session here, then we have a session. Next session will be in the TSI conference to be held shortly in the Chandigarh. Then we will have a session in our All India APAO conference in April. So unless we have got strong membership drive, probably we cannot achieve our success. And our sole aim of teleophthalmology is to screen diabetes and glaucoma in our day-to-day practice. And establishment of teleophthalmology network throughout the country. That's the most important, because many of us are doing teleophthalmology, like Elvipasa Institute, like our Sankarnatralaya, Arvind Hospital. They have a broad network of teleophthalmology. They are our guide, and they will be helping us in establishing a teleophthalmology network in the country. And I assure you, next 10 years we will see that teleophthalmology is one of the most sought after brands in ophthalmology. And always also we have to coordinate with the teleophthalmology, with the teleoptometry, because teleophthalmology is always part and parcel of teleoptometry. So without ophthalmic assistant, without optometrist, we cannot work together and we cannot move forward. Again, we have a TOSI Eco program. Shortly we will be coming with the TOSI Eco program for the CHOs, community health officers. They are again the source of first contact with the patients. So we move ahead with this. And I am the General Secretary of this Teleophthalmology Society of India. Dr. Natarajan was the president, and future president is Dr. Kim. And we got all some members are sitting here. So please promote this teleophthalmology in your society, state society. Have a meeting in your state society, so that we can at least have stay together, work together in the future. So with these few words, I welcome you all to become a member of Teleophthalmology Society. I welcome Dr. Jayant, Dr. Dinesh. I welcome you all to this program. So thank you very much for patient hearing and patient listening to me. Thank you very much.
Thank you, sir. Shall we move to the next speaker, sir, if it's okay? Dinesh, sir, can you join us here on the dais? Yeah. We'll move to the next talk by Dr. T. Sendil, sir, on teleophthalmology and business models.
Dr. Manoros, Navatika, you are here. Please do come, panelist.
Can I start?
No, come here, this side.
Thanks for the few of you who decided to come for this session rather than going to Rishikesh or Haridwar. So, I think, and thanks to the non-speakers, because most of the sessions I think we have a lot of speakers who are more than the audience. So, a lot of things start very small, and even the biggest of the ventures and biggest companies, biggest organizations, they start very small. And I think this small gathering will definitely within 3-4 years will become one of the largest gatherings for teleophthalmology. And incidentally, when I don't know how many of you attended the inaugural speech by G.N. Rao, where he also focused on the importance of teleophthalmology during his talk. And definitely teleophthalmology is not something which is for only the bigger organizations, because we always think that teleophthalmology should be done by institutions and not by individual practitioners. But I think teleophthalmology can be very much applicable to all the individual practitioners also. And over the next 5-6 minutes, I will tell you what I have done. I have made a successful business model out of teleophthalmology in the last 7-8 years. And so maybe it can be applicable to all of you also. And we had a lot of discussion with Dr. Subudhi as to how to improve the membership for teleophthalmology society. I think the members will improve when there is a business model, when there is a possibility of getting more patients out of telemedicine. And I think telemedicine is here to stay, and even the government of India is very much supportive of telemedicine. So the difference between market takers and market makers, there are two different kinds of people, isn't a product innovation, but it's just business model innovation. Basically it means like how do you execute it? So you don't have to do something new for this thing, but basically how we can execute it. And teleophthalmology is nothing but execution, because we already have the knowledge of ophthalmology and screening and everything, and the execution is the part which we all have to focus on. So, and I am sure regarding the legality, the telemedicine practice guidelines by the National Medical Council has been a boon, so that a lot of people had doubts whether telemedicine is legal or ethical and all these things. But with the telemedicine practice guidelines coming into play during the COVID time, I think that doubt has been cleared, and everybody can officially practice telemedicine. And in fact, the government of India is also doing telemedicine. So there is no need to worry about the legality or all those things. So what are all the different types of teleophthalmology? One thing we can, the first thing is direct to patient teleconsultation, like the patient calls you on a video call or through a software, and then you provide a consultation. Second thing is teleophthalmology in association with other healthcare facilities, like you as an ophthalmologist can have a hospital and you can collaborate with the surrounding general hospitals, diabetes centers, all those providers. Third thing is mobile vans, where you would have seen the large vans by organizations like Shankara Nethralaya, which is going into the community to screen. Vision centers, I am sure now many of the private practitioners also are trying to establish vision centers to reach out to the people who are not able to come to the hospital. And more importance, many organizations have been successfully doing diabetic retinopathy screening, and ROP screening also can be done through teleophthalmology. So these are the different ways in which, as a private practitioner or a smaller player also, you can do teleophthalmology. And I will give you my so this is the direct to patient teleconsultation, where a patient calls you and then you talk to him about a second opinion and other things. But in ophthalmology, there is a limitation in direct to patient teleconsultation, because you need details like visual acuity, you need anterior segment pictures, you need fundus pictures. So there are a lot of limitations. It's not like a dermatology or a psychiatry, but whenever you are doing a direct to patient teleconsultation, might be limited for ophthalmologists. So we don't actually do a lot of this direct to patient teleconsultations. So these are the limitations, and it can be you can even, maybe some of the hospitals have given a link for the direct teleconsultation on the hospital website. So if somebody wants to contact the doctor before he actually comes, just to send his reports and have an initial opinion, then maybe this will work. And it's mostly offered free of cost, just to get patients to the hospital. And there are various software platforms which are available for this, and mostly it can be considered as a marketing tool. Suppose say somebody from UK wants to visit your hospital, but he just wants to talk to the doctor before he actually comes or send some basic information about his details. I think direct to patient teleconsultation works in that way. And I think the most interesting or successful would be where you work in association with another healthcare facility, where you can actually set up a teleconsultation center in a diabetes center or in a general hospital, and then maybe there is an optometrist there who does the basic refraction and anterior segment image, all those things which are uploaded. This works slightly better because you have more information about the patient before you actually screen. So it's basically like you set up a teleophthalmology center in a general hospital, and you have a patient pool which is already there in the hospital, and consultation and opticals income can provide you revenue generation opportunities. And if there is a referral, it can also improve your surgical revenues. Diabetic retinopathy screening can be done in a similar way. ROP screening can also be done. So this is teleophthalmology, how it is done using these mobile vans, but mostly these are considered a charitable kind of a model where you have the funding, and then mostly done by bigger organizations, and then the cost of the vehicle, maintenance, financial viability might be questionable unless you have a funding resource for this kind of a project. So if you have funding, you can go into a mobile kind of a model, but otherwise I think it is not viable for a private practitioner. So this is the high cost of equipment, there is recurring cost, charitable funded projects, and patients may not be willing to pay because it is seen as a charitable, and mostly you can get the revenue from the optical shop. So this is something which I would like to focus on, is basically what I have been doing for the last 7-8 years, where we set up these fundus cameras in diabetes centers and or general hospitals. So any ophthalmologist who has a hospital, say doctor is in Barampur, so he can identify 10 diabetologists or 10 general hospitals surrounding his clinic, and then set up these fundus cameras. And there are a software platforms. We in fact created our own platform where we train the staff in those centers to take these images, because it's non-mydriatic, so any staff can be trained. There are reasonably good quality Indian cameras like 4S and Remedio and all these cameras, where you can train the staff in that particular center, and then so maybe I can take some time now, sir. So then images get uploaded, and you can use an ophthalmologist to kind of report those images, and patient gets a report. And whoever is normal can be called back after 1 year. Whoever has a problem can be referred to your hospital. So this kind of a network can be seen as an opportunity to get patients into your hospital, and patients also pay for each screening, and this is a financially viable model. And I have been running almost 300 centers now all over India, and every day 1000 to 1200 patients keep coming in. Just like teleradiology, teleophthalmology definitely has a role. And if you are if you run a private hospital, or if you are a retina surgeon looking to improve your patient pool, definitely this kind of a screening model will work. And financially viable model out of all the models, if you can execute it properly. And I'm sure this can be taken up by TOSI, where they can motivate other private hospitals to kind of organize these screening centers. And because so many, the volume of diabetes is so high, 300 locations is not enough. Maybe we need 3,000 or 30,000 locations to screen all diabetic people. And if 20,000 ophthalmologist members of AIOS, even if 3,000-4,000 of them take up this, launching 10 locations, I think there can be 30,000-40,000 locations which can be, and we are ready to help, and we would be happy if you want to know the model, or if you want to know about the platform, all those things we are ready to support through Teleophthalmology Society. So this is the business model which I just explained, and the diabetologist, here any model to be successful, I think everybody has to benefit. So the diabetologist or the physician, he gets paid for the reporting, and then ophthalmologist gets benefited either by the reporting charges or by basically getting more referrals into the center. And patient also gets benefited because he gets screening at the level of diabetes center. He doesn't have to visit the ophthalmologist for a normal checkup basically. So this increases the number of patients coming into the ophthalmologist. So basically a lot of patients, I'm sure even with advanced retinopathy, are still not going to ophthalmologist. So the more number we screen, more number of patients will come to the ophthalmologist. So that's the idea. So, and retinopathy of prematurity screening, large scale, it's done by Narayana Nethralaya and a few other organizations, can also be seen as an opportunity. Now it can be done through telemedicine, where the images get transferred online and then you can have an ophthalmologist or a retina surgeon looking at those from a remote place. So these are the newer equipments. This is a company called Globe Check, which has come with a Globe model for retinal screening for teleophthalmology, where all the equipments are placed inside a globe, including an OCT, and patient can go get self-screened and then get the report. And there are vision checkup kiosks like these, where you can get your refraction done. So there are companies which have come out with the vision checkup kiosk like these, and maybe if you are a private hospital looking to establish or market your hospital, these kind of kiosk you can set up in public areas, supermarket, and this is a company which has come up with kiosk. And vision center, I'm sure all of you are also exploring that model of setting up a vision center and then getting patients from those vision centers. So the most successful are the vision centers of Arvind and LV Prasad. And sir also mentioned about teleoptometry, because India has, I think, 200,000 plus optical shops where good quality optometrists are not available. So if you can kind of set up a teleoptometry facility where a centrally located optometrist is there.
Yeah, now it's, I think, time now. That's something now you conclude.
Yeah.
Yeah, all the speakers have already joined with us.
Yeah. So I am almost done, sir.
Yeah, please.
So these are some online visual field testing, a lot of developments in anterior segment imaging. Artificial intelligence is coming up in a huge way in ophthalmology, and yeah, these are my contact numbers. Thank you, sir.
Thank you, sir. Thank you for giving the good account of all these models available. Now we'll move on to next speaker. Now, I'm sorry, now all the speakers have already joined with us, so let us stick to the time only. So we don't have much time to, so let us, yeah.
Good morning, everyone, and thank you AIOC, TOSI, and especially Professor BNR Subuddhi sir for giving me the opportunity. So my talk is on teleophthalmology in India, how to overcome biases and enhance outreach. It's not moving forward. It's not moving forward.
Yeah, that's
So
no, it has come. It has come now.
click with the mouse inside the slides
Okay.
and then click right answer.
No, it's not working. It's hanged. Yeah, now it is moving. Showing something else.
Please. No, let's stick with it.
So, yeah, thank you. So what is teleophthalmology? So in short, it's a branch of telemedicine itself that delivers eye care through the digital medical equipment. It's again, it's not moving.
May I request the next speaker to,
Yeah.
So we are
Now-
moving now?
So these are the telecommunication technology. So these are the forms of eye care delivery via the real-time teleconsultation with an eye specialist. And why we need this teleophthalmology? Because the 70% of the population, Indian population, is residing in the rural or the tribal and the difficult geographical terrain areas. So it can be used in the ophthalmic disease screening, diagnosis and monitoring. Distant learning also can be used. And why teleophthalmology is a need of the hour? Because to provide equitable and accessible healthcare for everyone, serve underserved population living in the remotest of the areas, and India carries a varied geography and demographical features. And discussion of two doctors over phone to a complex patient-doctor interface or application can be easily done now. So there are types: synchronous teleophthalmology that enables real-time interaction between participants and the standard telemedicine technology, that is a video conferencing. And it is synchronous to supervise the removal of corneal foreign bodies also and for consultations. Then comes the asynchronous teleophthalmology in a store and forward method where data is captured and is transmitted for review at a later time by an ophthalmologist. So there are various programs running in India. In Chennai, by Shankara Nethralaya, reached more than 4.5 lakh patients since its inception in October 2003. Then this very wonderful kid drop from the Karnataka Internet Assisted Diagnosis of ROP started in 2008, and till now they have treated and screened 1601 infants in rural and remotest of the area. Then comes the Netra Antyodaya. This is a spearhead by me. It's a Government of Information and Technology initiative. So we are developing device just like Remedio, but that will be more economical, and it's slit lamp mounted for more stability, and it can 15 common retinal ocular disorders can be of the offline edge technology, AI based, so it can screen all 15 common retinal disorders. Now what are the reasons of biases in India? So we require high staff requirement in the remotest of area, and doctors don't prefer to reside in such areas. Lack of an inexpensive mobile imaging device that takes diagnostic quality images, and difficulty securing the public funds when the costs are incurred and savings are realized from separate funding envelopes. So when different ministries are involved, it becomes very difficult to carry out any project. Varied sensitivity and specificity of this AI algorithm, and most of them are not even validated. Longer loading time for images because of the slow internet connection. Multiple images they fail to upload at the same time. Poor color contrast and unavailability of red-free fundus images. Cloud image storage, chances of hacking, lack of education system, and the ophthalmologists and optometrists, most of them are not well versed with these new AI-based tools. And lack of well-defined legal framework, barrier in India, which demotivates the doctors over fear of malpractice. And the Indian Medical Council and Niti Aayog, they started effort to streamline its application in India. So what are the advantages of teleophthalmology? It helps in improving the patient care, strengthen the referral patterns, extended patient care and expertise to remotest of the area, education of hospital staff, clinicians and the community. It is cost effective, of course, and limit the spread of infectious and communicable disease. More effective planning and administrative meetings with point and click sharing of contact is possible. Video conferencing to the members of the Human Resources Department has helped to resolve the staff issues also. And the community nurses, ophthalmologists or optometrists, they can be trained with these new technology, and teaching sessions from the main hospital, thereby enhancing their knowledge and skills. And so how to overcome biases? So first is education and sensitization. Align teleophthalmology with the NPCB and the Vision 2030 programs. Mobile ophthalmic units with digital devices and loaded with AI applications, validated of course. Development of economical slit lamp photography, portable AI-based non-Mydriatic fundus camera, more perks to the optometrists and ophthalmology who are ready, willing to work in the remotest of the area, and greater internet connectivity and bandwidth. So in conclusion, digital health will be revolutionizing healthcare delivery just like the advent of computers or smartphones. So there is a strong need to adapt with the changing technology. And AI technology with teleophthalmology can have innumerable benefits, fruitful outcomes if various concerns of patients and doctors are adequately addressed. Thank you so very much.
Thank you, Dr. Maurya. I think it was very enlightening, and you are spearheading the project.
Yeah.
So we'll learn more and more about AI and new apps and benefit.
So it costs, right now we have Remedio.
Yeah.
So it's costing 4.5 lakh, but we have developed our offline S technology loaded. It will costing 1.25 lakh.
That's great.
With 15 retinal disorder, it can detect.
Very good, very good. And if we get NPCB and Vision 2030, then of course.
Yeah, government is saying that they will try to provide it to all the CHCs and all that.
That's very good. That's very good. Thanks a lot. Thank you.
Thank you, sir.
So with this, we move on to the next speaker, none other than Dr. Sanjeev Mittal, teleophthalmology at AIIMS Rishikesh. Happy that you have introduced these services and you'd like to know more about it. Please.
Good morning, House. The services at the AIIMS Rishikesh is in the preliminary stage, basically. So just want to share, like, without the other means, how we started. In fact, this previous speaker had mentioned already something, so I will try that duplication should not occur. Teleophthalmology, in fact, telemedicine is it's a branch of telemedicine, and in fact, we all of us actually have been using it since long. And with the advent of the telephones, particularly first initially the dot line telephone, then mobile phones, so everyone is actually using that. So it is not something new. But however, for the community basis, like there are certain now means that how we can go ahead. So we the telemedicine, actually this application can be either like a video form, I mean according to the mode of communication it can be categorized, video, audio or text based, and according to the individuals involved, patient to doctor, doctor to doctor, optometrist or nurses to doctor, and according to the timing of information transmitted, real time interaction or asynchronous exchange of relevant information, and then according to the purpose of the consultation, I mean first time consultation and follow up consultation. So with through the mobile everyone has been experiencing it. So this telemedicine, actually this model teleophthalmology is based on hub and spoke model. The center is a hub like the base hospital, and the peripheral places, centers where we are installing our equipments or gadgets, where the optometrist or some trained person would be transmitting to the base hospital and interacting. So just to show you this, actually this I mean we have a telemedicine center in our place, and this is not moving. Can I run the video? Can you increase the volume, please? This is with the Lal Bahadur Shastri National Academy of Administration, Mussoorie, nearby here, and they have a tie-up with our AIIMS Rishikesh, the telemedicine. So ophthalmology is also assigned one day, like every Tuesday. There's a hospital, one medical officer is there, and paramedical staff is there, and when they need, like they communicate, we have a base hospital. Our base hospital, we have telemedicine center where there is a staff, and they inform, like today they need a consultation, otherwise we have a fixed days. So then it's not necessary that I would be coming to attend that. It is anyone can go, like who's accessible, available in the ophthalmology department, will reach our telemedicine, that setup we have established in our institution. So our otherwise teleconsultation
also we can do. So this is the patient is a cellulitis patient, they can communicate with the doctors on that. So sometimes this patient, we collect disease from that ambulance. So then we can become a ready in the OT. In a high profile setup, we can become a ready. So we can wear all those things, and by step we can do all 3-4 surgeons, we can get together, we can save the life. The pulse was not there in this patient, is eviscerated done, and then we reconstruct all. Business point of view. So that some patients, I am here now, they're calling, can I come to my clinic? No, I am out of station, so come on Monday. So this is a one kind of a business model. So patient, and we can reduce the harassment also. And some are just calling what are the things, then accordingly we can. Teaching, some of our colleague, if they want to talk with, so they are patients, so please share, then I can instruct them immediately. So I am follow up my residents are changing this. I did just one day ahead that transcranial orbitotomy. Now comfortably I am instructing them. So that's a very easy. So but there is some limitation, is like depends on network connectivity in some rural areas, short period, and poor quality of photography from some. If that your other end, there's a mobile was not up to that mark, so there is a one issues. And of course in glaucoma, retina is not possible those. So I want to conclude in that the smartphone based diagnosis is significantly comparable with a standard clinic based examination in some cases, or with a teleophthalmology big setup also we can serve the people. Thank you.
So how does WhatsApp, messages are legally?
No, like I had a similar doubt, like one of the slides I saw, Dr. Jayanta giving a differential diagnosis to the patient. Like that they will be doing a Google search of those differential diagnoses, and then probably that may stand against us in future. Like you should be very specific in what you can deal with the app. Only I think that much information should be shared on the telephone.
Sir, maybe MBBS also, but is registered to him personally, not to the patient.
Correct.
Yes, sir. Correct.
Okay.
Thank you, sir.
That's like when Dr. Subodhi made me a panelist for this session, since that time I was thinking like what we can do from AIOS. So it's just a loud thinking as of now. Let's start working on an AIOS teleophthalmology app. So,
yes, sir. Very good, sir.
Hopefully, like
great help for us.
Some spade work is already done. Yes. So probably we can have that app in our website, from where a member by getting an OTP can download that app, and we will have a similar app for interaction for the patient, but that patient app has to be on the public platform. Let us work on it, and hopefully in the next year or so we should be trying. And in that, if I need, I will be taking all of your help. Prasanna, you should help us. Subudhi, Prasanna.
Yes, sir. Sir, if you may add.
Yeah. Let us explore the possibility that, like, I have a loud thinking as of now, like, let us work for a basic EMR also. Like all the institutes, they have their specific EMRs, high-end EMRs, all the institutes and big centers, they have their own EMR. Let us plan one basic EMR for a startup clinic, like our youngsters, so many people, they are coming out. That is the basic requirement. Like, so I'm just giving a loud thinking about a basic EMR and a teleophthalmology app. We'll work on it. It's just a concept as of now. It's just a concept as of now. Let's work on it.
So just to add on a point on smartphones, there have been some of the articles which we have also worked on is the ASP done by Dr. Prithvi Chandrakant. So a simple 30 diopter lens, if you are going to use it on a smartphone, you can actually image the anterior segment of the eye in high magnification. If you are going to use 4 30 diopter lenses, one above the other like a piggyback lens, then it is actually going to be like a simple microscope. So So during COVID times, we did one publication in IJO innovation section where ROCM cases could be actually be diagnosed, at least the high filamentous ROCM cases. And another thing is the trash to treasure red cams, T3R, again published in our IJO itself, where the focal point of the 20 diopter lens, when it is placed in such a way, we'll be able to visualize the fundus. So a simple bottle of that particular focal length and putting a 20 diopter lens, it becomes a fundus imaging as well. So I think it's a very beautiful time. We talk about AI, but actually imaging also is there in smartphone, where anterior segment and of course we need to dilate the eye to take the fundus with the smartphone. Yes sir, yes sir. So these are things that are up and coming, and I think with Santosh Anavar sir also we are trying to work one on MRD1, MRD2. Can we measure the LPS height with the smartphone, just the imaging of it? And there are so many things which are very promising. Yes. So one paper from, a quick point before we move to the next speaker. We also, there was one paper on congenital glaucoma where a U-tool was devised to measure the vertical and horizontal diameter. Yeah, thank you sir. With that we'll move to the last speaker of the day.
No, I just wanted to add that there are already n number of existing apps to be used in the smartphone at our doctor's disposal. So, but most of those apps are very complicated and we have to pay a huge price to use it fully. So, I think some app should be developed that is easily accessible.
Yes,
I think AIOS can play a big role, and this will help all the members actually. EMR, this teleconsultation platform. These are the ideas which we can probably take shape under Santosh and Dr. Manoj's leadership. Thank you, sir.
Okay.
So with this,
Over to now Dr. Parikit Gogates is from Pune, the top practitioner in Pune, and he does a lot of teleophthalmology work in Maharashtra. So I would like him to share his updates.
Thank you, Dr. Subudhi, sir, for the opportunity. This is a very simple presentation. It's a very small work that we are doing compared to all the stalwarts who have presented. We have a mobile clinic linked to our 3 vision centers. The mobile clinic has a chair unit in it. It has a handheld slit lamp, a portable autoref, and a fundus camera. So we all know what teleophthalmology is, but this is a vision center in Saswad, which is a rural area of Purandar Taluka. It's about 1 hour's drive from Pune, and this October we have finished 1 year, and we are trying to make that entire taluka of about 90,000 people free of avoidable blindness with Operation Eyesight Universal. So I'll not go into the basic concepts of teleophthalmology and the need, because all the greats have presented it and what all can be done. But from our side, we use the fundus camera, we use the eye care tonometer, and we use a handheld slit lamp. So one is fixed in the vision center, and the mobile eye clinic goes around in the periphery to do with that. So this mobile van and this vision center that is there in the Saswad, so there is a door-to-door screening by which patients are screened and they are asked to come to the vision center. But many patients don't come to the vision center, in which case if we have some identified that in this locality there are, say about 30 people who have vision less than 6/18, then this mobile eye clinic goes there, and there that comprehensive eye examination is done and it is relayed by phone to an ophthalmologist. And in case they suspect diabetic retinopathy or glaucoma, then they dilate and they take an image and they share it with the ophthalmologist. So generally, first vision checking, if it's a cataract patient, again refer to the vision center. If it doesn't come to the vision center, we go in the periphery and see them there. If it is not a cataract patient, then it is only refraction or IOP screening. Then that is something that we do in the periphery only. So here, so far, about nearly 19,500 patients have been screened by door to door. And we also link this with school eye screening. We also link it with Wari, because that area there is a lot of pilgrimage that is there, and also spectacle dispensing and surgeries. So here we don't have much data to show and prove, but it is helping us, because when we had done a similar study in Yeravda earlier, we found that even if cataracts are identified, those cataracts don't come to the vision center. If we say we are giving subsidized surgery, they say no, we'll wait. When we say after 1 year, okay, we will do it completely free, they will still say no, we'll wait. It's only when their vision really drops below 3/60, that is the time when they actually agree to do it. Now this is only for cataract. Now this time when we are doing it in a rural area, we are also doing it for glaucoma and for diabetic retinopathy, to give a more comprehensive this, and also trying to cover low vision. So this is just a thought from our side, is how we can use teleophthalmology more so as to make it more effective. That's all the rest is mostly theoretical, so I will not go into the details of that. Thank you. So we have our own NGO, Community Eye Care Foundation. So our clinic only has that. It's kind of our NGO. Most of it is financed by our paying patients, so they kind of look after. But we also have a technical collaboration with Operation Eyesight Universal, who are based in LV Prasad Eye Institute, Hyderabad. So for the technical guidance, how to do door-to-door screening, how to do the quality assessment of that, Operation Eyesight, we have been their partners for last 10 years. So they help us. So in urban areas, where it is say about within 5 kilometers of the clinic, it has worked very well. But when we are trying to do it in a rural area, it is, I don't know, it has been a year, but somehow we have not been able to make a mark as much. Even though there are 3 healthcare community health workers, there is a trained optometrist, there is an optical center. The mobile eye clinic goes, which also has an optometrist and ophthalmic assistant. So even in spite of that, in spite of screening about 20,000 people, we have not been able to do that much of service delivery as we should have. So no sir, no. Glasses they buy, but again they generally wait, because school glasses we give free. When there are camps for pilgrims, for Wari, we give them free. So uptake is there, but we have never been able to sell more than say 50-60 specs a month. We do get revenue, but no, I mean not. So in fact we have submitted it to the Indian Journal of Ophthalmology. When we had done it in Yeravda Vishrantwadi area, that was from 2015 to 19. In those 4 years, we had spent about 36-37 lakh rupees, because that was completely on our own. We didn't have any funding, and we had earned about 40 lakh rupees. But most of the earnings is from surgery. That too subsidized surgery, say 5,000 or 10,000. OPD was 30 rupees. So even if the center is say 10 patients a day, the revenue is only 300 rupees. Now it has become 100 rupees. But yes, it is a challenge. So I think earlier they said that for the mobile van and all, if you have a funder, then only it is that way viable. Otherwise, then somebody is subsidizing it. Yeah. In our case, our paying patients are subsidizing, and to some extent now Operation Eyesight has given us a small grant. Yes, it's a service, yes. At least we could make an area of about 50,000 persons free of avoidable blindness. So that's a satisfaction we have. But no, we have never made great money in that. So when the van goes, the van generally has one optometrist, one internee optometrist or ophthalmic assistant, and a driver. Yeah, and it is linked with a ophthalmologist in the clinic.
Good.
Yeah.
That is the model we want, that it should be popularized. In our country, because most of the people are in the rural areas, unless you screen them for diabetes, glaucoma, and simultaneously you get the cataract for your revenue. But these two diseases, they are not screened properly. So it will help you by the mobile vans. So that's one of the concepts. So thank you very much. I
Thank
think
you,
you've
sir.
given a
Thank
quite
you
good
for the
concept from
opportunity.
your center. And I thank all the speakers. Definitely they've given some side their experience for our teleophthalmology. And last but not the least, our president of AIO has given good news to us that they're coming up with a teleophthalmology app, which will be helpful to all of us. So definitely I thank you. Yeah, maybe we'll be listening in the APAO meeting. I think we'll get some news in the APAO meeting in April. So, but however, in your tenure, I wish that this should be done.
We'll work on it.
Thank you, sir. Thank you very much. I thank all the panelists, I thank all the speakers, audience, and my colleagues for participating in this wonderful session. And really, I would say that it's a very successful session. I request all the speakers to come for a photograph. We'll take a photograph. Thank you all.